All righty, ladies and gentlemen, we are live.
Good afternoon and welcome to the Eureka Springs Hospital Commission on December 15th, 2025. Can I have a roll call, please?
Kate Dreyer, Secretary.
Brian Byler, Vice Chair.
Sharon Doremus, Commissioner.
David Carlisle, Commissioner.
Willie Daniels, Commissioner.
Tiffany Means, CEO.
Sandy Martin, Chair.
Velvet Schultz, Nurse Executive.
Cynthia Asbury, CFO.
Jody Edmondson, HR Director.
Vivian Smith, Commissioner.
Okay, we're all here. Thank you all for joining us today. First thing we'll do is entertain a motion to approve the minutes from our November meeting. That should be November 20th, not October 20th. From November 17th. Sorry, I'll get my act together.
I so move.
Second.
Thank you. Okay. Any discussion? All those in favor say aye.
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 Any opposed? Okay, so moved. Thank you. Approval of the agenda for December 15th. Do I have a motion to approve?
So moved.
Any additions or addendums?
I second.
Okay, David, you? Okay.
Made the move.
Any additions, corrections, discussion?
Additions?
Yeah?
You want me to talk about it now or just?
Do you want to put some, do you want to, this is putting something on the agenda?
For today?
Yeah, or do you
Yes.
want?
Yes, I do.
Okay.
You want me to talk about it now or?
No, just the agenda item.
Detox, alcohol detox at the hospital.
Okay, we'll put that under new business, under number 11. Okay, now do I have a motion to approve the agenda as amended?
So move.
Thank you. Do I have a second?
Second.
Thank you, Willie. All those in favor say aye.
Aye.
Any opposed? Good. Public comments, there are no publics, so we'll go on to CEO report. Tiffany?
Well, good afternoon.
Good afternoon.
Everybody. I wanted to start out to say that November was just a little slower month for us. It is typical for the winter, but despite the seasonal trend, we are really actively implementing strategies to enhance outpatient services and improve patient experience. So these efforts aim to stabilize revenue and strengthen our community engagement during the winter months. So we're experiencing a little bit of what has been typical trended in the past. And during these times, we take opportunity to see how we can further enhance and, again, serve our community during these times. We continued our alignment with Arkansas Department of Health, Arkansas Hospital Association, REH for rural sustainability and financial resilience. Weekly leadership huddles focus on operational efficiency and cost containment. So Cynthia and I are continuing to work through her knowledge and her experiences and sharing with me. Still, I'm learning the operational and the financial pieces based on the REH model. So there's still, even though she does the financials, I still have questions that come up. So this is our time that we vet through that. Infusion Center, that has been something that we came out with in the past month, and we are looking to expand infusion services to the hospital. We shared this during our open house, the area that we have all prepped and ready to go, And then we had a regional provider meeting a couple of weeks ago that Sandy and Jody went to that shared that this is a program that we're going to start implementing after the first of the year. So we will be networking closer with the clinical providers to ensure that we are all working towards the same goals, is to treat our patients locally with the orders of infusions that they would like to see here. So we're vetting through that menu to make sure that through pharmacy that we can stock it reasonably and being able to schedule these patients to come over and have their infusions in our newly renovated place. We are continuing to look at our facility infrastructure and needs and grants opportunities. Sandy and I had conversations with the REH corporate office last week, and we are looking at different avenues and all the grants that are possibly available to apply for that would be specific for us to be able to do. So after the first of the year, they're going to be giving us a list of all of the grants that we would be most likely be eligible for, and we'll be able to apply. And that there's a lot centered around behavioral health, mobile service clinics, telehealth, a lot of those things. So there's a lot out there. We just need to make sure that we're eligible for those and be able to apply for those.
And can I interject
Yes.
on that? And we also discussed the possibility of creating a separate 501c3 as a municipal-owned quasi-government commission. We can apply for a lot of grants that are available, but there are some foundation grants and other traditional grants that we can't because we are not a 501c3. So we're having our attorney look at that option. The hospital has had a 501c3 before, and that was, in between different management companies and things. So this will serve a different function, but it's probably a wise option for us to do. So hopefully we'll be able to discuss that in January as well. Okay.
All right. So outpatient growth, we're going to continue exploring additional service enhancements to attract patients during our historically low ED volume time. Okay. Our CLIA licensure remains in good standing, and we are now moving towards emergency preparedness planning and drills. Clark, our director of facilities, is leading this into the 2026 with planning with the chief of police, the fire chief, that we can coordinate some disaster plans around emergency management and those things. And so we'll be conducting drills and working on some environmental safety things with the chief of police as well. 2026 is a good year that we're going to be establishing, developing, and working internally on some of these things that are actually required. So they just have not been formally conducted in a way that we need to have those in order for compliance. Chief Floyd of the police department also has joined our workplace violence committee at the hospital. He attended our second meeting. He came to one in November, and then he just came to one last week. And we really value and appreciate his willingness to participate. He's also helping us coordinate efforts to make sure that we have this strong connection with, if we have a safety event at the hospital, how quickly can dispatch bring us somebody there. And so we're going to be conducting a drill and doing some times and doing some of those things. Also, we're looking at, Clark had installed some panic buttons for staff who may encounter a workplace violence or safety concern. But right now, that button doesn't directly go to dispatch. And so Chief Floyd and this committee were working together this past month to see how we can coordinate those efforts to, all we have to do is punch the button, dispatch is contacted, and they can send somebody along the way just to get him there. So we're going to be working on that. Financial performance overview, our gross charges, Cynthia's going to explain a little bit more. They're down a little bit from October by $344K. Our net revenue year to date is $6.58 million versus prior year was $8.2 million. Our operating margin was just slightly a little bit negative due to our low volumes and seasonal trends, which that was to be expected through that. So one of the things that we're also working with closely with our medical director is observation patients. We don't seem to have very many of patients that actually are observation patients where we can stay. They can stay a little bit longer, and we can treat them a little bit longer. And so working with Dr. Roberts, we're reviewing case by case to see how well we can better serve our patients to maybe stay under our watch just a little bit longer, just to make sure that they're doing well. So we're going to be working on some more observations. Cost containment measures remain in effect. We continue labor and purchase services. They are trending downward, and that's a good thing. That's through the efforts of Cynthia and Velvet in that manner, and they'll share their, I don't want to burst their bubble, so they'll share those type of things. But strong liquidity position is maintained despite the monthly variances. Workforce and culture, we continue to revise and update our policies and procedures to ensure compliance and regulatory alignment. That's something that when I came in, there was just a lot of gaps there in years of reviewing and updating to the current rules and regulatory. So we have really boasted out a lot of new updated policies based on the current guidelines. December, we're having weekly snack days, and this helps encourage, we're already doing really well at coworker engagement activities, and just helps continue to keep that morale going. The energy is strong. The staff is just come in, they're smiling, they're happy to be there, and
It's because you make pancakes for them.
Oh, we made waffles last week.
Waffles, yeah.
And Jody was making popcorn today for everybody. So today was popcorn day.
And we get nothing. Okay.
Yeah, we didn't bring you anything, did we? Guess I'll have to drop by, have some popcorn.
There you go.
After the show, right? Facility and infrastructure, this is something that Clark, again, his report shared with me. The HVAC replacement has been completed officially. Our flooring installation is pushed to January. We're still working on to secure some solid bids. We've had some hiccups there with trying to get some vendors out there, and we felt like we need to go a different course of action with some of these vendors. So we're still working on that. The helipad tree removal project is completed. We've had, how many aircraft have we had fly out in the last couple of weeks? Couple, 2, 3? Yeah.
Couple of weeks.
The pilots have made a great notice to how they felt a lot safer flying in, and we did a great job with that. Our boiler survey, they passed state inspection. One boiler remains active, the other is decommissioned, and that was due to the new HVAC system that we took down that boiler, and then we have the other boiler still in place. The chiller and compressor was removed by our vendor, and the mini split installations are still left for room 3 and 4, and they're scheduled for early 2026. Generator tests, what we have found on our generator tests is previously that some of the equipment that we needed to be on generator were not on generator. So when we did this last test, Clark and Terry walked through and went through and went to all of the outlets that needed to be on generator, identified ones that were not there, and then rewired and hooked them up to generators. So additional plugs and wiring were added that for equipment readiness. We've had fire drills performed successfully. The incident response, we had a smoke detected in the ED last month that was coming out of the vents. We contacted the fire department. They came out. We did a lateral evacuation. We had 2 patients. We did a lateral evacuation. And they came in and with all their drones and everything just to make sure that we were all fine. Somehow it was honed into something, smoke inside a vent that had already just went out on its own. So probably when we turned on the heater, there was a little bit of residue possibly in there or something burning, but then, but we're all good with that. So I wanted to say thank you to the chief and his crew for coming out so rapidly and making sure that we were all fine. And they were absolutely very organized and very serious about making sure that everybody was safe, and all the coordination was perfection there. So great job to them. We had a structural risk assessment done for the 1927 building. I don't have the report of that yet. We also had an assessment done of our fire sprinkler and alarms, and I don't have that report yet. So they were walking around the building a couple of weeks ago with their clipboards and marking through stuff. So as soon as I get that, I'll report that out at the next meeting. Our call light system is fully functional now. And then that's it on facility. Community engagement and patient satisfaction. We're still accepting community patron interest for our patient advocacy committee. Our first meeting is scheduled for January 2026. Our patient satisfaction November highlights. We did see 191 ED patients in November. We had 20.4% of ED patients that actually received the call, gave us feedback off of that. A lot of times we leave a message, we try again, they don't respond, and some just don't want to participate in the survey, so which is fine, we respect that. But all of the responses we had for the ED patients was 100% positive in that. We had a Google review in the meantime. The Google review was needed to visit ER on the night of Thanksgiving for a laceration to my daughter's head. Staff was quick and courteous and did their best to keep a toddler calm despite a fraught situation. Kudos to the whole team on duty that night. And then we had a callback review that a father called to let us know that he really appreciated everything that Rich, our registration person, did for his son while they were there in the emergency department. He said that Rich went above and beyond to help make his son comfortable, and he was all around amazing, and said that he listened to them and was very compassionate about their situation. So that was a callback to our team on that. So that is it. That's all I have to report.
Sounds like we're getting a lot more engagement with patients. Are you
Yes.
finding that?
Yes. So any questions?
Nope. All good? Okay. Cynthia, financial report?
So in the financial packet, we'll flip past the cover sheet. The next page is our bank account balances ending 11/30. You'll see it was down about 4.6% difference between that to October. Again, we anticipate that within our decrease in volume coming in, I mean, claim payments and things within that, the timing variance of that. Next page is our daily charge, or our charge review. And again, it was down. Trended, it's about historically where we were last year, given the, reduction of the service lines when we don't have currently compared to what we had last year. It's kind of our seasonal average there. But just really, it was an overall decrease in ER visits and the complexity of those visits. So within the charge service, when the next page is the income statement for the month of November. Again, you'll see our outpatient billable revenue definitely was down. As you move down through the page, you'll see our contractuals kind of anticipated within that. Then down to our expenses are within line of where we see. I mean, there was a bit of an increase in our expenses, and I can go into detail on that in just a minute as well. But within that, I mean, our labor wages kind of has stabilized. It's kind of plateaued. I think we're where we're going to be within our staffing of the matrix, within where our salary expenses are with reduction of contract. So then the next page is going to be our balance sheet for the ending of 11/30. I have nothing really to note off that. So the last page is just going to be some of our KPIs from within our Oracle Cerner revenue cycle. Just kind of just show you some of the things within our system, what it can track. And mostly of that is just what they call the Millennium financials. So just looking at our AR, accounts receivable balances throughout the time, our charges, and like our days not final billed and stuff. So all within reasonable on that. And that one's on the packet I gave you. I do have some other notes just to kind of go through. And again, like I said, I mean, our revenue to volume was definitely a decline from October to November. It was, again, driven by the encounter volume decrease. No real material changes in identifying payer mix, although we'll definitely be watching payer mix as we go into January, February of 2026 to kind of see how we land with patients who change from a Medicare to Medicare Advantage, kind of watching to see how the Medicaid kind of situation plays out. Anticipate a lot more self-pay within that. The premiums within the Affordable Care Act are going up significantly on, families that are purchasing plans. So, I mean, there will be a lot less even insured, I feel like, within the commercial. So it'll be a big kind of determining, especially in that first quarter, to kind of see where we fall compared to historical. Within the expenses, I did note that we did have an increase. Part of that was because we had the $94,000 one-time HVAC expense that hit and was reported in November. So with that kind of backed out of our expenses, again, our expenses were where we kind of track and trend them to be between that $550,000 to $600,000 per month. So within that, I mean, our accounts receivable overall did decline. Continuing to work that. Continuing to kind of see within that. Sometimes it's a payer delay. Sometimes it's a coordination with patients because they've given us an insurance, or a loved one has given us an old insurance card or something because they just grabbed it out of their wallet, not realizing. But within that, I think everything else, it's about all I have on the financials. So.
And just as a point of reference, if you remember in our June mid-year budget review, we anticipated a deficit this year. And it's still a little too early but to predict exactly what will be. But we talked about an $8.5 to $9 million revenue and a little bit over 8 to 9 in expenses, not counting the discounts and everything. So we were looking at between $250,000 and $350,000 deficit. So looks like we're kind of on track with what we thought in June with it. And the offset is when we had $496,000, I think, for Pinnacle with
Correct.
that.
Well, we've paid out, for server infrastructure repairs and upgrades. We've had the HVAC upgrades and things, unanticipated expenses, even that we weren't, anticipating at the beginning of the year. So
For all we spent this year, it really looks like that negative is still not bad considering how much we've outlaid in costs.
Yeah, I mean, and we're showing, like October was great. We had a couple profitable months, and then, this time of year it's slow, but it's not a surprise, and with the unanticipated expenses, I think, we're coming in pretty much where we expected to come in, right? You think it's
Correct.
going to be deeper?
I don't anticipate, too much more. At this time, I hate to kind of say, but nothing, unanticipated for the remaining 15 days of the month. So I think we'll be pretty stable. Did have a slower week last week, but we've had some good weekends. Some numbers have kind of, so looking at that, so I'm like, it just kind of.
I've got a question. It basically, Tiffany was sharing stuff. This infusion program that we're bringing to the table is an outpatient service, correct?
Yes.
Correct.
I know you guys have done your homework. How does it look overall? Is it we're excited about, I know when we were there at the get-together, the open house. What's your feelings about this program as an outpatient program for our hospital? Does it have a lot of profitability to it, I guess? What's your thoughts there?
I think the startup first quarter is going to be pretty flat until we get it established, with the clinics that are ordering the infusions. Okay. So I think when Cynthia and I talked, I think we said the first 3 to 4 months flat.
Correct, yes.
Yes.
Okay.
And then hopefully we can, start seeing some revenue generate after that.
But do you guys think the infusion program, I think just from talking just a little bit, it sounds to me like it's a very good program to bring to the table for outpatient services. Am I thinking correctly there?
Yes.
Not just I don't want to call it, not just an addition to kind of complement but it's actually something we're going after that's going to benefit in a larger scale. Am I correct in thought? I'm not real familiar with how that whole program works for
Yes.
infusion and what.
When Jody and I met with the, whatever they call that group. Regional Health Coalition. It was a docs from Mercy and from Wash Reach. And we mentioned that was a new service that we were going to be expanding. And they really responded positively to it. There's a huge need, and evidently there are some vacuums. So there'll be a lot of education to go with it too, with the providers and with the public, to let them know that their infusion is now available locally, more than it has been in the past. So,
And it's economics as well. So based on need and demand. And one of the things that was brought up is something about oncology. So let's just say for right now, it's not out of the window. It's always in the picture, but there's a lot of regulatory things around oncology, especially infusions and stuff like that. What we want to do is we want to start out with a menu of things that are most likely a demand of the providers that will order. And then based on the demand of how many patients are needing some oncology infusions, then we can build that case. So we're going to start out in a medium cocktail of infusions here, and then based again on the number and the need, we can go into other areas.
because that'll obviously hit our pharmacy, right?
Yes, yes.
So, in other words, we'll have services, that menu to provide. We will sell it or advertise it to providers all over the region. And it's up to them to decide that a patient's from Eureka or close enough to Eureka. How do we get that junction where the patients might actually have a say in recognizing there's an advantage to be treated near home?
Right, and when we get to that point, I think our patient advocacy committee could help some of that, because in the community, they're going to bring things to the committee that are basically from community members that they're going to be sharing. And this is the opportune time for them to be able to share what they would like to see. This is why I wanted to form the Patient Advocacy Committee, is to get more of a community engagement and see what they would like to see us have more of those. Now, it's one of those, like, if there's one person that would like to have this one item, would that cost benefit us to have that one thing? And you just have to weigh it out. But also working closely with the clinics like Dr. Loudermilk, I plan to follow up with him to say, out of your clinic, let's talk about what you would send us. What kind of infusions would you send us? We've already had an orthopedic come and share with us what he would like to see. And so we just build up on those type of things.
So it's kind of working it through almost individual practices.
Right.
To get it.
Different
get it rolling.
specialties, yes. And you have to have a physician order, of course.
Right.
So that's where it comes from.
Does that include blood transfusions?
At this time, again, we are looking at that. Blood transfusion is a whole other thing, and we don't keep a lot in our blood bank right now. And we do it for our emergency trauma patients based on the trauma guidelines is what we minimally stock. But that's definitely not off the table. But right now, we're not going to start out with that offering until we get more of a demand for that.
Thanks.
Any other questions or comments?
The infusion patients are very much planned and scheduled. They're used to that type of treatment regime, whatever their provider is. Most all have a case manager looking to get their services closer to home that will work with case management to make sure drugs have been ordered. We can guarantee when they'll be arriving, because there's such a vast amount of drugs that can be done in infusion. You really need to be planning ahead of time for, is that weekly, is it monthly, is it twice a week, so we can make sure those drugs, you can't really afford to keep some of them on hand. You got to plan that ahead of time. So we'll be working pretty heavily with the providers and the case managers for those payer sources to make sure that we can get the drugs and get the patients scheduled. And then the blood infusion is kind of the same way. The biggest risk that you have when you go to do blood product transfusion is if you ship the product and then the patient, for whatever reason, can't have their infusion, and then you're stuck with $1,000 worth of blood and it's not even as much the cost as you have to waste the product, that you may not be able to send it back. Some of it you could, some you may not be able to.
So as we look at that, you bring up the third point. Other hospitals, facilities are doing infusions, and I guess the thought of, is our cost outlay going to kick us in the backside if we're not careful with what we're doing? I guess that's my concern, is now that you mentioned that, what does it do to us as far as exposure to,
Well, when you work, the whole idea of case management is to weigh out, can something be cost effectively done outside of an inpatient setting, both for the provider, for the facility doing it, for the patient. And that's where that really comes in for us, to work hand in hand with them to say, it's kind of, think of it as like a bidding process for them to say, hey, what can you guys do this for? And then we have to weigh out the cost of the drug, the manpower, the time allotment of it, and then give them a price. And then that's where the negotiation starts. Can we do it and afford to do it? And is it cost effective for us to do it? And sometimes you'll find out it's not cost effective for us to do it, especially when you're buying a drug per dose. In your large facilities, especially your acute care facilities, they're buying it in bulk, so they can afford to do it a little bit cheaper. But, even the oncology drugs that Tiffany referenced are not always chemotherapy drugs. The issue is mixing chemotherapy drugs. The cost of them obviously a little more expensive, but in the oncology suites, they're mixing a drug that they're going to open a container to use for several different patients that day. That's the way they're scheduled for that day. But some of the oncology patients are getting non-chemotherapy modalities that we would be able to do. But again, it's really where case management rolls in for us to work with them and say, yeah, we can do this, or this is not something we're able to do for you. So it's really going to be a case-by-case basis for those patients.
Question. would the prescribing physician's office be responsible for making sure that a prior auth has been completed and the approval come through, or would that be a nurse at our infusion center who would be required to have that on his or her plate, running down those prior auths?
Kate, I would answer yes to that.
Which one?
All of the above, because it will weigh on, in the offices, their job is to get a hold of the payer source for that patient who has case management and say, hey, we want to do this. The patient's interested in doing it closer to home. Here's an organization that does it. And then on our part, we don't want to start a treatment that we don't have prior auth on hand to do. Now, we may submit information to the case management or to the physician's office about what we can and can't do. Do they need monitoring? Is it an 8-hour infusion? Is it a 12-hour infusion? Is it an hour daily? You know, how does that work? And it's really, the reason I answer yes is it's a collaborative between everybody having all of their ducks in a row to do that. And we very well will have face-to-face with the insurance companies and the case managers for those patients.
So the clinic's staff would work with the case manager and get that prior auth rolling, but before we put the patient on our calendar, we would follow up with the insurance company or the case manager, who would be working probably with the insurance company or for them, to make sure the prior auth was in place.
Yep.
Okay.
Well, we would want, especially the day before. Now, we would obviously do it when it's scheduled, but especially the day before, to make sure drug is appropriated, the patient's going to be able to be there. Do they understand the time? Case management understands the process. You know, it will be a little bit of a dance to start doing that.
Well, but it hedges your risk management, or maybe hedge isn't the right word, but it certainly lowers risk exposure, maybe
Sure.
I should say.
Yeah, absolutely. And for the patient as well, for everybody to have their ducks in a row.
But obviously, we've looked at this and said, this is a win-win situation.
Definitely.
To offer.
Yes.
You know, I mean, it sounds like a very positive situation overall.
Yep.
Yeah, and that's where I was going to say, is that it sounds like this has been looked at as a good revenue stream for us.
Yep.
And it's come up with RHRQ in their SLAY report, service line expansion report. It came up in one that we did early on in the end of 2024 for REH. So, I mean, it keeps coming up.
Well, the rural emergency hospital ERs have everything you need. That's the advantage that you need for an infusion suite. You have full monitoring. You have all of the diagnostics if they were to have labs before they had their meds. If the physician wants labs in addition to the infusion, we're able to do that. If they have accesses that need to be flushed or dressings that need to be changed, you know, you have nurse paramedics. We have all the monitoring. Essentially, we're still a hospital.
Yeah.
You know, we have everything we need to be able to take care of those patients.
Very good. Very good. Very good.
Anything else actually, that was the financial report. But it's okay. It all comes together. It's all the same thing, so. Any questions, any more about infusion, and Velvet's about ready to give her report, anything for Cynthia? Okay, Velvet, you're on.
I gave you guys just some volume metrics just to glance at for year. I was working on trying to get everybody's just about caught up with year to date. And probably our couple of pretty exciting things for us is we are 2 to 4 weeks away from being contractor free in the ER. We hired our last full-time paramedic. We're hoping that we get a start date from him tomorrow. We're waiting to hear about that, and that will make all of our staff. We want to be respectful to our last traveler. She'll be with us for a little while longer till we get that person transitioned into their position, but we will be contractor free come January.
Excellent. Is that 5 paramedics now or 4?
There's 5 paramedics.
Excellent.
And this one is coming off of a truck in Harrison, out of the Harrison area. We spent some money for our trauma grant. We bought a new ultrasound to be able to do vascular access and abdominal exams in the ER. We bought a GlideScope, which is an advanced airway piece of equipment for our physicians if the patient has a difficult airway to be able to establish it. It's kind of a standard, really, in any emergency room to be able to use that. We have a McGrath, but our physician had asked for an additional apparatus, and it's referred to as a GlideScope, and the trauma grant purchased that. Cynthia and I were able to work a little bit of information to get some pretty decent used equipment. It's very gently used, but the pricing was ideal for the volume that we have and for the usage. And we bought some new lighting for the emergency room for the physicians to be able to suture with. Our lighting is literally from 1967. A little bit difficult to get parts for and a little bit difficult to be able to see. So we have some new lighting. And we also bought some additional training equipment for the sim lab, a port access device to teach both patients and families and our staff how to properly access a portacath that goes up in the subclavian vein. And then some additional IV access trainers to be able to start lines with some of our lab staff who don't draw a tremendous amount of blood, and as well for patients as well. We're pretty excited. We spent about 18 grand for our of our trauma grant, of our $40,000 grant for that, which we're pretty excited for them. And we need one more gurney weigh bed, our beds that weigh. We have 7, and not all of them have a scale in it, which is kind of a problem for a really sick patient or stroke patient, especially if you're basing drugs based on an accurate weight. So we're trying to get those traded out so we can have, we'll just keep buying them as the grants allow us to be able to buy them one at a time. Yeah, I think so.
Okay. Anything you want to highlight on this at all?
No, it's just data, just what we keep all the time. It gives you a little bit of information about our patients' length of stay. Working with our physicians and our clinical staff about it's hard to be too critical of them. The minute they see a patient hit the waiting room and hit their screen, they go get them and bring them back. And they're not always good about logging immediately onto their computer to sign them in. So the care starts long before the charting does, but this keeps track of when the charting starts. So sometimes our physician door-to-doc time is a little longer than I'd like it to be, but it's just a computerized number. It truly is not as long as it would appear. We continue to have a length of stay issue for patients being transferred out. Not any foreseeable change in that in the upcoming future, short of a truck that is parked with us, and that's not so unreasonable. Probably. You can see the amount of transfers, is obviously during the tourist season, we transfer more patients out. EMS volume remains strong. I feel like it gets stronger every month. Actually, in November, we had a record high this year of EMS transports in. It's about 23% of our patients come via EMS, and the industry average hits you right around 21%. So those guys are doing a little better, keeping those patients in the community with us, and we appreciate that.
And one thing that we are working is Chief Inman have a monthly collaboration. So he was we had a meeting this month just to go over things, just to make sure we have a great relationship. We talk about what's happening on their side, our side, anything. So we're continuing our partnership with them just to make sure that we're all in this together.
Yeah, I've had nothing but positive feedback, so I know we're definitely doing a great job, from my inside source.
Yeah, and being an inside source, I tell you what, I've got nothing but positive feedback about the hospital there, and so it's just great. And going out there now is like night and day as to what it used to be like. So it's an awesome job out there.
And Willie, I'm going to still encourage that group off from Inspiration Point and Grassy Knob. Some of those guys need to come in and see the hospital and take the tour to try to encourage. I think we've got some great things in that area. As many people as they see a year. I think what I say last time, about 150 I think they had near 150 calls last year. So, I mean, that's a pretty good percentage. And with that group out there, there's some good people out there that are part of those two volunteer groups. So I'm encourage them to come in and get a hospital tour.
We'll extend an invitation to them.
Absolutely.
Yeah, I think it's, there's a lot of folks out around the Beaver Lake area that we're servicing, and I think that's crucial. Those guys know that we really care about what they're doing.
It is, because there's nothing out
Yeah.
there, and they just
No.
automatically go to Rogers.
Yeah.
Yeah.
Well, and we monitor our EMS traffic. We have the radio and we monitor it, so we kind of know what they go on and what's staying here and what's going out of here.
Sure.
And we continue to try to educate them to make sure they know stroke, STEMI. We're maybe small, but we're very capable, and time is of the essence with those patients to get them to us as quick as they can instead of waiting on an aircraft. We can practically have everything rolling with them, meds on board, before they can get an aircraft on the ground with them. So we're continuing to make sure they understand that we have that capability. Not all of them really do,
Right.
because we're small and we're rural, but, for a stroke and STEMI, we're certified with the state. We can flat move a patient of either one.
Anything else for Velvet? No? Okay, HR report, Jody?
Yes. Since the last meeting, we have onboarded 2 registered nurses and 2 lab techs. So our staffing continues to grow locally. The year-to-date turnover rate is 6%, and the past 3 months is 7%, and so far for December, we are at 0.
Excellent.
And
Good. Anything for Jody? Anything? Okay. You were sent the QAPI, the Quality Assessment Performance Improvement Plan. That's next on the agenda. Hopefully you reviewed it, and we need to get that approved. So I'll entertain a motion to approve and/or discuss the QAPI.
I have a question for Jody. I'm so sorry. Did I hear you say that for November, we're down to 0% turnover?
month to date for December.
For
is
okay,
at
thank
0.
you. Sorry, Sandy.
Sorry.
I so move.
Okay, do I have a second?
Second.
Thank you. Okay, all those in favor say aye.
Aye.
Any opposed? Okay, thank you. Next up is the approval of the risk policy that you also got a copy of. Any questions on that? If not, I'll entertain a motion to approve.
Who's the policy owner, the lead in the risk program?
I'm sorry, what?
Who's the lead in the risk program?
The lead?
Yeah.
That would be Tiffany Means.
All right. I'll put your name on it.
Yes, sorry.
I thought so, but I thought.
Buck stops there.
Motion to approve.
Thank you. Do I have a second?
I second it.
All right, all those in favor, say aye.
Aye.
Any opposed? Okay, Kate, you're on with detox at the hospital.
Can you hear me okay?
Yeah?
All right. Since we last met, I have visited with the city council member and with the mayor. I've also visited with people associated with one of the local alcohol and drug rehab programs in the area. And it seems that if our REH regs will allow us, that alcohol detox could be a community service, a revenue source, help keep the people who would like to become patients at the area rehabs, instead of having to do their alcohol detox someplace else before they can come in, they could do it with us. Because what happens sometimes is a patient will get accepted at one of the rehabs, but they'll show up drunk. And I don't know if it's a level of what the Roberts would call alcohol poisoning, but definitely not well enough to be driving. So, you know, some IV care to get that blood alcohol level down so they can go ahead and get into their rehab bed. Another thing that has come to my attention is that we probably within, I would guess within the next 12 months, Eureka will become once again a place of healing and recovery, because we have a few of our motels that are being turned into sober living apartments. So, and it seems to be happening pretty rapidly, and these places are pretty big. So, y'all have already talked about observation beds, and, you know, up until now, we sort of had a limit of 23 hours, but we also knew that the regs were allowing us some overage, and that, you know, I guess you would track those hours every month, because you would know in a 12-month period how many overage hours you could have. So if we were doing really well on not having other overages, then maybe these 23 and 9/10 hours in the observation bed for our alcohol people, we might could give them 36, or we might could give them 48 hours, and that would get them patched up well enough so that they could go to their rehab bed. So I think those are, and then eventually, if we figured out this was something we could do, then eventually we could go to and meet with the administration of these rehab centers and let them know what we can now give their patients. And then, as y'all have brought up, go to all of our 3 area EMS services and say, you don't have to take this alcohol person all the way to Rogers or to Berryville, that they can come and get that care and get that blood alcohol level down and get them safe. So that's what I have to say. Thanks for letting me share.
With all due respect, we're doing it. We are seeing these patients. EMS does bring these patients, and they come by private vehicle. And they are monitored over a period of time. We draw serial blood alcohols until they get to an acceptable level. And we start hitting the facilities that they would like to go to, because those facilities will dictate a certain blood alcohol level that's acceptable, and they want certain labs drawn, certain medications given, and we're actually doing that. Maybe not in a formality as a program, but we see a fair amount of patients requesting. They're requesting detox to go to treatment, or the facility gets them and they realize that there's a medical concern for a drug amount on board, and then they come to us and we hydrate them, give them some medication to help with that detox period, and then serial blood draw them until they get to the whatever level. All the facilities dictate about the same level, but they are certainly different in what their medical director requests, if it's blood alcohol or drug screen or whatever it is to be.
So how many observation bed hours have we been able to utilize for the alcohol folks?
Well, under the REH, we are under regulatory where we have to consider, we can only keep our patients' observations 24 hours or less. So you have to start considering transferring that patient once they start hitting that golden hour. Anyway, we just can't keep. Is that what you're going with on that?
Was I mistaken then on that
So
a cumulative,
Correct, you're correct, Kate. So it really with the REH and the billing and CMS, it's the cumulative average. So as long as your average length of stay for ER visits or for observation care is 24 hours or less, and that looks at your whole bucket of everything, it's not patient by patient, it is the average on that, Kate, from what the CMS that we read, yes.
we could have somebody for 36 if they
We did,
just
yes.
couldn't get the vomiting under control or whatever their symptoms were. Okay.
What have
Yes, we just have to document our efforts and justification as to why the patient's there for anything beyond that. But yes, we can have, it's the average length of stay, it's supposed to be 24 hours or less. So,
Okay. Thank you.
you're welcome.
Velvet, we've been, has that pretty much been the norm? They've coming in for 24 and they're gone? We're able to get them in there.
You're normally able to get them in and out in less than 24 hours.
Okay.
You know, and it just depends, everybody's different.
Right.
You know, the patients are all different. It depends on what their initial blood alcohol is or the drug they have on board. Are they having associated symptoms, you know, seizures, cardiac issues, high blood pressure issues, you know, what you're treating them with. But most of them stay acute because of that, because you're hydrating them, you're giving them additional medicines to help with the withdrawal. You know, so they, instead of flipping them to a 23-hour OBS, they're still staying as an acute stay because we're continuing to draw labs on them, medicating them, you know, doing things you would do in the acute setting with them.
Is there any outreach, since this is something that you've been doing? I mean, I'm sure that my thought process was that some alcohol folks do trickle through, but would there be any benefit of having the area treatment folks and the EMS folks know, hey, this is something that we do and we do well?
Yeah, absolutely. And certainly the treatment facilities in this region, there's actually a fair amount of them per capita, which is interesting, are definitely on Tiffany and I's hit list for 2026 for outreach. Because I think probably the thing that's the biggest deficit is I think they perceive that we don't want to take care of those patients.
Yeah.
And we 100% want to take care of those patients.
Yeah.
We actually take care of a lot of the patients from the treatment facilities here, you know, because they're very good about making sure they have access to us and then that they have a ride back and that there's communication and a report is given about what, you know, we see probably more of them that hit the treatment facilities and then they discover they have a need.
Yeah.
So then they bounce to us and then we treat them and are able to bounce them
Send them
back.
back, yeah.
Where maybe and maybe that's what you're saying, Kate, the real need is the initial treatment before they go to the facility. You know what I'm saying? Because I think it's sometimes wasted time or effort that they get to them when what they need is medical clearance.
Exactly.
That's what we refer to it as, medical clearance.
Exactly.
Because so they bounce back. You know what I mean? They get to them, then they go to us, and they go back, where maybe they should come to us first. If we could get the treatment centers to direct them to us first, but, you know, sometimes they don't know what they're getting.
No, not till
You know,
they hit
they don't
the
know the
door.
status of the
Sure.
patient or the condition of that patient.
And these folks coming from treatment centers, they're covered by insurance. I think I'm correct in that idea. So it's not we're not offering free health care.
Majority of them are covered by insurance.
Okay.
But we'll take care of them either way, Martha. If they need treatment or they need detox, we don't care what kind of insurance they have. We'll take care of them either way.
If it was just maybe a more formal offering.
Sure.
So that they would know, hey, you don't have to. And I'm just going to predict a little bit that if these sober living beds really boom, there may be one or two more rehab places
Sure.
who come to Northwest Arkansas.
Well, and they need to appreciate that we can take care of their acute care needs for that. But, you know, we've spent the latter part of 2025 making sure we're capable before, and I know we've talked about that. We want really bad to hit the street and tell the whole world what we can do in a marketing outreach sense, but we've really needed to spend the last several months to make sure the infrastructure, the staffing.
Oh, of course.
Even simple things all the way down to regulatory and policy, that all of our ducks are in a row, because we certainly have a pretty aggressive outreach plan for 2026, early 26.
Did I not pick up early on in our conversation today about that we wanted more time with observation? The observation side of our business needed to be more addressed and try to get more
Yeah.
time with observation, right?
Yep.
So we're
Right, and we've been, we had a meeting, Velvet and myself and our medical director, Dr. Roberts, we met on Friday and further discussed that a little bit on strat plan and all of that. So he's highly involved in that, is truly engaged into, making sure that we can offer the observations.
And it's definitely a learning curve for our providers, even for our clinical staff, to realize, they can pretty quickly identify you can't go home by yourself. But then we need to make sure they remember, but they can stay with us for a period of time, and which patients are appropriate for that. Because I think we as ER providers, we've been so oriented to you're subdividing patients, you're either going or staying. You're either going to go home or we're going to send you somewhere, but you're not, once you're done with us, but it's a learning curve to remind our people you can stay with us for a period of time if that's appropriate.
So basically just getting our folks, our staffing understanding what we're able to do and what we should be trying to do.
Yep.
Thank you.
Thanks for bringing that up. It was a good topic.
Yeah, for sure.
Thank you. Okay. Tiffany, got a small little project to discuss, the
Just
budget?
little. First, I want to say thank you to Cynthia for taking time to be patient with me as we go through the proposed plan for budget. I had gone back to her a couple of times wanting more in-depth information, and she did some great work there. So I want to acknowledge Cynthia for that. This budget has been developed with a very conservative and disciplined approach. We've grounded in historical performance, current utilization trends, and the realities that are facing rural hospitals today. So as a rural hospital, we must be thoughtful in how we plan, balancing access, safety, and sustainability. This budget is not about aggressive growth or speculative assumptions. Instead, it reflects responsible planning to design and to ensure that Eureka Springs Hospital remains stable, accessible, and financially sound. I think we all agree with that. So I want to frame this discussion about what guides our decision making. And you'll remember this because I've shared this the last commission meeting. Margin through mission, growth through accountability, care through community. So as we go through the budget, we're going to start off on the revenue side, revenue assumptions. So again, grounded in historical utilization and actual patient volumes is what we're looking at. We did not assume increased utilization, improved payer mix, or changes in reimbursement. Instead, we plan conservatively around how services are currently used and reimbursed. Outpatient services and access-driven care continue to represent a significant portion of revenue, and we're reflecting on how patients in our community seek care today. So when we look at this, we are focused on key service area where community need is clearly demonstrated. Emphasis is placed on delivering care at the appropriate level to improve efficiency, reduce unnecessary high-cost utilization, and support financial sustainability. Because of the many unknowns we are facing in 2026, the budget will remain a working budget. The commission and leadership will continue to do quarterly reviews, and if adjustments are necessary, they will be made during the standard mid-year budget review process. So does anybody have any questions on so far? On the expense overview, so on the expenses, again, we're very disciplined in our approach for operational efficiency and sustainability. Stewardship has been something that has been at the forefront since August, and Cynthia and Jody have been working those from January until August. So we continue to be on the same mission and path. Staffing expenses reflect current workforce levels with adjustments only where required to maintain safe operations and meet regulatory requirements. The budget prioritizes the workforce stabilization, productivity alignment, and minimizing reliance on contract labor where possible. So the budget reflects a continued focus on reducing contract. However, I want to make a note that keeping some form of contract labor in our budget is necessary due to core staff vacancies and the time required to recruit, onboard, and train permanent staff. As positions are filled, contract labor usage is expected to decrease again. Velvet has worked an outstanding job at creating a culture of inclusion, positivity, and focus. And I think that engages the team to want to stay for purpose and mission. And truly, I see it every day when I round. They are happy to be here, happy for the patients. And I feel like Velvet's work has been very strong in that aspect to reduce contract labor and to bring in qualified staff that can take care of any emergency that would come in through the hospital. Supply, pharmaceutical, and purchase service expenses are budgeted conservatively as well, based on historical utilization, contractual obligations, and known inflationary pressures. There's no discretionary expansion or non-essential capital investments that are assumed. Overall, expense planning supports long-term stability while ensuring continued access to safe, high-quality care. Does anybody have any questions?
Just to top line it a little bit, the revenue goal is 14 million with the REH reimbursement and 12 million without. The budget was viewed as, what if REH goes away? Can we sustain? What benchmark do we have to have? And the assumptions clearly prove that we can sustain. And with or without that, a couple of points too, the RHTP revenue is not included in this, nor are there any grants outside. Those are the aggressive grants we're going after that Tiffany mentioned, not the standard ones that we get like the trauma grant. So that could potentially be additional revenue, and it nets us down to 8,821,000 on that. You've got some charts that look at percentage of budget. On the expense side, our expenses are projected, and you've got the percentages and the line items. The total expenses come to 8,292,56 and some change, which gives us a slight profit of 528,963, and I think Tiffany was actually going for a break even on that, weren't you? But you messed up, so on the good side. With the quarterly review and with Tiffany continuing the 16-week rolling budget adjustments, there are some things that have been flagged that if we have significant changes in revenue decreasing, there are some things that could be postponed or moved. They're big chunks, You can see from the revenue distribution or the expense distribution, facility is a huge jump. It went from, we spent approximately 11% of our expenses in 2025 on the facility. It's going to jump minimal to 26%. And the purchase services have reduced, but you see those percentages in the investments of what you've been hearing about the equipment and the service line that still aren't quite adjusted, that Tiffany and Cynthia are working on. But things like the parking lot and the helipad restructure, while we really shouldn't put those off, push comes to shove, those are things we can, we can't eliminate supplies, pharmaceutical, labor, things like that are pertinent to the care, with it, but that can be put off. Also included in this, and we have not heard from our, whether we got the grant for the mobile clinic transport van yet. They're still reviewing it. So we don't know. We've put $125,000 in the budget for that. We, A, may not need it, and B, we may have to postpone that. So you've got a little over, close to $300,000 that we can not consider in the expenses, push comes to shove. But I think that pretty much covers it. Do you have anything else?
On the contractual labor, that includes the doctors, right? This figure, the 1.6 million, that includes,
Yes.
that's our contract with them also?
Yes.
And then also then room for, if we have to pick up some contractual nurses to fill in, that's all put in that figure there, right? That's where it's at?
Yes.
And facility improvements, as far as things go, I know we're on 100,000. So we've kind of, would I say we lowballed that a little bit, or am I?
Yeah.
So on that, if you're looking at the line item on that facility upgrade, we went very high on that one just because of the unknowns of the facility. Because then we do
Okay.
have our general repairs, which is kind of where
Where
our
the money-
typical what we budget every
Okay.
year amount. And then kind of down through there is the big projects that we anticipate, but again, can be put on hold. But just of the unknown facility upgrade is at that 100,000.
That's, I mean, I think it's for what we've got going on over there, I think it's a great idea. And I think the grant program thing, as far as some of our money to upgrade some of this facility stuff that needs it, I mean, hopefully the grant money thing will be a door open that will help us to cover that side of our cost.
The whole facility thing is just a wild card.
Yeah,
I mean,
absolutely. Absolutely.
they're also considering, like, where do they move? Should, because we've got all the offices in the old building.
Right.
And we can't take a risk, at all.
No.
It's got to be safe, and the employees have to be safe.
Absolutely.
So there's, we
Oh,
need to be prepared for higher
Right.
prices.
We have spent a lot of money this year, though, overall. Been forced to spend it on some upgrade stuff that, I
But
mean.
most of that has been in the patient care areas. The
Yeah.
HVAC units, everything has been
Yeah.
more in it's been all in the 1970s
Right.
building.
You still got to
forward,
wear your parkas in the old building
Yes.
in these, few of these days this winter, all right?
Yes.
Yeah.
Yeah. Well, if you look back at this year, and I shudder I won't even ask for a list, but I would love to see it sometime. The upgrades and the investment in this facility and what has been done, it's tremendous.
Yeah.
It's incredible. And I imagine it'd be several pages long in what we've done by choice and then by grudge.
Which is a good thing. We've put some things behind us now that, as we move forward, we can put focus on other areas, knowing that we've spent a lot of money on the things we really needed, which I'm excited about that idea, that we've got those things already taken care of.
Well, and I think in, Tiffany's strategy and with Velvet and Cynthia and the staff too, without those investments, that investment, we wouldn't have the foundation to launch these new services.
Yeah, that's right.
So they kind of went hand in hand. We had to do that. And it just so happened that this year we had to handle a little bit more, but some of it was planned, some of it was not planned. But it puts us in a solid position,
Yep.
and a launching pad for 2026 with the service lines they're looking at. So the one item, and Tiffany and I discussed this too, and it's come up several times, the one item that is continuously low that we'd like to see more money in is marketing. because we're going to need to be a little bit more aggressive. They're doing everything they can with community outreach and all that stuff, but that's physically removing them, you know, from the facility and putting them out in the community. But we need more in there. So, I mean, I will be kind of harping throughout the year and months that if we have any slush funds, we need to put it into marketing and give them a little bit more support, you know, in that way. So, any other questions or comments? How do you feel about the budget?
I have a question. In my ignorance, under the purchasing services, the Forvis, 100K for audits, would the city split that with us since
No, ma'am.
if no pretty
us.
please with sugar on top ain't going to happen?
We're going to
Okay.
try to work with the city and Public Works to be able to offset some of the costs on the parking lots. But no, that's not theirs to do.
Okay.
It's ours.
Had to ask.
Sorry.
And so-
I know. And to go back, it is high. But, and I learned this, and maybe you all know because I wasn't on the commission at the time, that when the commission was looking for an auditor, to find one that understood medical and rural hospitals was very difficult.
Yeah.
And of course, Forvis rises to the top when it comes to that. So evidently, y'all, prior to my being involved, made the decision that your attorney and your auditor were going to be hospitalists.
So within that note, Kate, I'll also add, they do our annual cost report for CMS as well. And just in my tenure being here in the 3 years, I mean, having them be able to file our cost report yearly versus a previous entity has saved us several $100,000 every year. Because when we were previously filing our cost reports, we were paying in annually to CMS and Medicaid upwards of over $300,000 sometimes. So,
Paying for itself,
So,
it sounds like
correct,
then.
yes.
Yeah, thank you.
Good point.
Good auditors
Good point.
can.
Cynthia?
Any other questions or comments? Vivian, anything? No?
I like it.
Tiffany, any more? No. Wow. Okay. So with that, I will entertain a motion to accept the 2026 budget as presented by our CEO.
So move.
Thank you, David. Do I have a second?
Second.
Okay. Who did that?
Sharon.
Sharon? Okay. Thank you, Sharon. Any further discussion? Okay, if not, all those in favor say aye.
Aye.
Any opposed? Okey-doke. Great, good job. Thank you so much. There was a lot of hard work that went into
Yeah,
this.
obviously, very
A
good
lot of
job,
crunching
very good job.
numbers and a lot of unknowns. And we're going to still have some unknowns, and hopefully this is truly, truly conservative. But Cynthia, thank you for all your time and
Yes.
effort into it. It really makes a difference. I think through the process, we are getting smarter about it and understanding more, so I think that's a great thing. Speaking of marketing, you've all, we've got a draft of a generic new brochure for the hospital that you've all been given. And look it over. If you see any changes or anything or typos, let us know on that. I think that's it from this standpoint. So Commissioner comments, and I'm going to start with the Lone Ranger Commissioner over there, Vivian.
Yes. Nothing, a lot of hard work, and thank all you guys, really. It's an incredible place.
Thank you. Willie?
I'd just like to say, I mean, the improvements I've seen just alone, and with, I'm looking forward to 2026, so I think, great job, everyone.
Mr. Carlisle?
Likewise, I think it's a great job saving the hospital to begin with, and then taking care of the problems that are there while preparing to do the next stages is just a pretty wonderful job been done. Thank you.
Sharon?
Ditto. Just ditto.
Brian?
My hat's off again to Tiffany and Cynthia on this budget. I know Sandy's involved too, but great job putting this thing together. In I say a short period of time, I think. You guys have done an awesome job there, and just incredible operation going on at the hospital. I mean, we look back 12 months ago, guys, and look at this thing. Look at this thing. The diamond in the rough is starting to, really get polished, but great job. That's all I can say.
Kate?
Well, I think that's a really good picture to paint, is that diamond is really starting to shine. And all of us are acutely aware of how to put it, the cleanup and the attention to detail that's been required month after month after month. And you kept coming back, and all of you kept coming back, and you came on board, and you're still here with us, and you're committed with these wonderful ideas. And y'all did do an incredible job with the budget. And yeah, just Merry Christmas, and thank you so much.
Thank you. It's going to be a great new year, I think, for all of us. And I can't add any more than what's already been said, but just deep gratitude for the hard work, the detail, the attention. I mean, you have a question, there's an answer, or if not, they'll go get it and figure it out and come up with 12 more questions to fire back at you. So that's a good thing. Wanted to also bring up, you've got a calendar for our 2026 meetings. There's been a request, Tiffany's requested, she's running into conflicts with some meetings, that we move our meetings, keep it on the same days, but move it from 2 o'clock to 1 o'clock. Does that work for everybody? Is that okay?
I don't know.
Huh?
Your January, February, and June meeting all fall on hospital.
Employee holidays, I know. We'll, as we get into that, we probably won't have anything in January. I don't know, it depends on the budget. But yeah, I know, I saw that too. So, but I didn't want to move it a different day of the week, and I will need to check and see, but I'll check on all of those. Okay. So we're okay at 1 o'clock?
Yeah,
Okay, I'll confirm that with the city and make
Thank
sure
you.
that's okay.
And that's on regular meetings and workshops just across the board. We're now at 1 o'clock and not 2.
Correct.
Okay, thank you.
On Mondays. Yep. With that, again, I want to thank everybody for the work and the knowledge and the experience. Our community is benefiting greatly from it. And I wish you all a happy holiday season, Merry Christmas, and a great New Year. It's going to be great. Stay healthy, stay warm, and kick some butt. Here we go.
Thank you.
Do I have a motion to adjourn?
Motion to adjourn.
Okay,
Second.
Second? All right, all those in favor, no question. Goodbye.
Aye.